Thank you for joining Cancer Support Community Atlanta for the Tell Me More series. This program provides an overview on multiple myeloma and is led by Dr. Rudolph with Georgia Cancer Specialists. For information on other installments, please visit Cancer Support Community Atlanta's website at cscatlanta.org.
Hi, my name is Dr. Priya Rudolph. I'm with Georgia Cancer Specialists with Northside Hospital Cancer Institute. We're going to talk about multiple myeloma today and break it down so it's easier to understand. So what is multiple myeloma? Multiple myeloma is a blood cancer, and it's a cancer of what we call plasma cells. These are cells that normally are found in the bone marrow, but they're a very small percentage. They're normally less than 5%. When the plasma cells divide uncontrollably, you can get multiple myeloma. So what are plasma cells? If you look at a healthy bone marrow, I call bone marrow the factory of blood cells. It makes white cells, red cells, platelets, and if you look at the white cells, a B cell white cell is what forms plasma cells. Plasma cells help with immunity of the body. They actually make antibodies. However, if there's a damaged white blood cell, a damaged B cell, you can get abnormal plasma cells, and that's what becomes multiple myeloma when it is in an uncontrollable manner. And one of the characteristics of these abnormal plasma cells is that it tends to make what's called as M proteins, and we'll talk more about that as we look at this further. Multiple myeloma is the second most common blood cancer in the world. There are about 160,000 new cases diagnosed each year worldwide. And most commonly, this occurs in patients older than 50 years. I have seen occasional patients that are less than 50 years. I have 2 or 3 currently patients in a younger age, but vast majority of these patients are in the 70s, and average age at diagnosis is 69. For whatever reason, men are 1.5 times more likely than women to get multiple myeloma, and the prevalence is twice as high in Black population compared to white population. 5-year survival rates, fortunately, have increased tremendously since 1975. When I started my career about 20 years ago, patients with multiple myeloma lived about 2 or 3 years. Now, a lot of patients go into long-term remission well over 9 or 10 years or even longer because of multiple advances that we have made over the past years and continue to make in this field. So while multiple myeloma is incurable, the good news is that this is any more similar to managing high blood pressure or diabetes. It is a chronic condition and it is highly treatable. What I also tell my patients is that multiple myeloma treatments are mostly outpatient and contains a combination of pills and injections, very easy to do. Most patients go on about their lives, they travel, they work as they're doing treatments, which makes it very similar to a lot of other chronic medical conditions. When we talk about multiple myeloma, we're looking at 4 main criteria to classify someone as a patient with myeloma. This is called the CRAB criteria. C in CRAB stands for elevated calcium. R stands for renal insufficiency or kidney disease. A stands for anemia, and B stands for bone abnormalities. Many times, a patient will come to the emergency room with weakness, fatigue, confusion, maybe some constipation, and if you check their blood levels, you might notice a very high calcium, which might trigger you to think about a diagnosis of multiple myeloma. We also run into patients that have a high serum creatinine or a new kidney dysfunction They may have symptoms related to that in the form of nausea or vomiting or decreased urination. And that again might make us want to look further to see if that patient has multiple myeloma. Multiple myeloma can also present with low blood counts. So anytime I see a patient with low hemoglobin that is not easily accounted for, we dig in further and do additional blood tests and find out that whether or not this is related to multiple myeloma. As the blood counts drop and patients become anemic, a lot of times they will present with weakness, fatigue, sometimes infections if they're dropping the white count. And then occasionally we'll see patients that present to the emergency room with a new fracture, or they may have thinning of the bones noted on scans. They may have holes, what we call lytic lesions, noticed on a random scan that they're getting for other reasons. And that might, again, trigger us to think about a diagnosis of multiple myeloma. There are 3 different main plasma cell disorders that we run into in our routine clinical practice. The most common is called MGUS or MGUS. This is a non-cancerous condition, but it can be precancerous. And what it really is in this condition, there is notable abnormal protein in the blood. However, if you do a bone marrow biopsy, there's less than typically 10% of plasma cells in these patients, and they do not have what we call the CRAB criteria that we just talked about. On the other hand, patients with active myeloma typically have a high M protein, more than 3 grams per DL, and also have plasma cells in the bone marrow, which is typically more than 10%. And these patients often have one of 4 CRAB criteria that we just talked about, or one high-risk feature, as in more than 60% plasma cells in the marrow, or a high serum-free light chain ratio, or an abnormality detected on MRI. There's also a condition called smoldering myeloma. This is where it's between MGUS and active myeloma. These are patients that are smoldering and may progress to myeloma. In these patients, the M protein is at a high level, for instance, more than 3 grams. The bone marrow has more than 10% plasma cells, but they do not have any other symptoms. They do not have any CRAB criteria. Patients with smoldering myeloma can progress to active myeloma at a rate of about 10% per year. So 10 out of every 100 patients with smoldering myeloma will go on to develop myeloma in a year. On the other hand, for MGUS, that number is 1% per year. Multiple myeloma is stratified based upon risk categories, what we call a revised international staging system. And there are 3 stages based upon laboratory abnormalities. We have serum beta-2 microglobulin level that we look at, serum albumin, chromosomal abnormalities in the bone marrow, as well as LDH. And depending upon where these levels are, they fall into either stage 1, 2, or 3. However, it's important to note that anymore in a clinical practice, we do not put a lot of weight on staging as much as the chromosomal abnormalities, what we call a myeloma fish panel, that actually defines the risk of that patient as far as progressing and or responding to treatments. There are several diagnostic tests that we do routinely to make a diagnosis of multiple myeloma, as well as to follow along the course of these patients. We check their blood count, called a CBC, a comprehensive metabolic panel, to look for calcium levels, kidney function, other electrolytes. We do something called a serum electrophoresis. The name of the test is serum protein electrophoresis, and we also run IFE or immunofixation electrophoresis. As I had mentioned previously, we typically are looking for something called M protein or monoclonal protein, and we follow that level serially over a period of time to see if that number is coming down. For instance, if I see an M protein at diagnosis, say, of 5 grams per DL, I'm looking for that number to slowly drop down to undetectable levels as we're doing treatment. We also look at measurement of immunoglobulins. And typically in multiple myeloma, at diagnosis, they will have significantly elevated immunoglobulin of a certain kind. For instance, there might be elevated IgG level for somebody with an IgG kappa myeloma. Another very important test is called serum free light chain assay. Here we're measuring kappa and lambda light chains. The normal numbers for kappa and lambda light chains are typically less than about 25 or so. When somebody has a myeloma, there is elevation of either kappa or lambda light chain, and the ratio is altered. The normal ratio being 1.65. If that number is altered, we hope that with treatment, those numbers will start dropping and get back to the normal range. So these tests are very routine, not just a diagnosis, but also upon follow-up of these patients. In addition, we also do a 24-hour urine collection. Not all patients will make protein in the urine, but for those patients that do make protein in the urine, this is a very useful test to quantify the amount at diagnosis and continue to monitor it as we go along. This abnormal protein is called Bence-Jones protein. And in light chain myeloma, it is very helpful to follow these light chains in the urine because those patients will typically make a lot of protein in the urine. In addition to blood tests and urine tests, imaging studies are done typically at diagnosis and then to document remission and for periodic monitoring, no more than every 6 months to a year. For initial diagnosis, we typically do a PET scan that will light up bone lesions or lytic lesions throughout the skeleton. It may also show tumor masses composed of plasma cells in different parts of the body. A CT scan can also be used as an imaging study, although less commonly used. A skeletal survey is a quick and easy way to detect any holes or lytic lesions in the bones and simply involves doing x-rays of multiple bones throughout the skeleton. An MRI is a little more detailed scan. A lot of times we will do an MRI of the pelvis or spine, again looking for these bone lesions. And lastly, we may consider doing an echocardiogram. This is particularly a useful test if we're suspecting amyloidosis, which can affect the heart. A bone marrow biopsy is a very key, important baseline evaluation, as well as evaluation down the road. This tells us the number of plasma cells. As I had mentioned, the normal number of plasma cells in a healthy bone marrow is less than 5%. And as we detect higher percentages of plasma cells, that not only helps with forming a diagnosis, but also helps to look for relapses or monitoring during the treatment course. Rarely, we might choose to biopsy individual tumor sites, what we call plasmacytomas. These are patients that form tumors containing plasma cells in different parts of the body. As we do different biopsies, we typically send out for what's called as a cytogenetic testing, and that helps us to look for chromosomes, as I had mentioned, a myeloma fish panel, which will tell us what type of chromosomes an individual has. And based upon these chromosomal translocations or abnormalities, we can predict ahead of time if someone is high risk or low risk, or what we call standard risk myeloma. We might also choose to send it out for DNA testing. And with all these tests together, we are able to then formulate a treatment plan for our patients. As I had mentioned, bone marrow biopsy is a very important test that provides a lot of information about multiple myeloma. We look at the bone marrow morphologically, meaning looking at it under the microscope to detect the numbers of plasma cells and if there's any other abnormalities. We also run it through a machine called flow cytometry that will pick up these abnormal plasma cells and will tell us if a plasma cell is abnormal based upon whether or not it is what we call clonal, meaning kappa restricted or lambda restricted, depending upon whether kappa or lambda light chain is elevated. And then we also send out cytogenetics, as I had mentioned, which is looking at individual chromosomal changes, and in particular myeloma FISH panel looking for well-identified abnormalities that we normally see in myeloma to see whether a patient is at a high risk or standard risk. This is a very important test for a proper staging as well as disease assessment to determine treatment. Very common laboratories that are sent for multiple myeloma include serum protein electrophoresis that we talked about, that quantifies the amount of M protein that we follow along. Also serum-free light chains, where we quantify the amount of light chains that we follow along, either kappa light chains or lambda light chains, as well as the ratio. And for those patients who have protein in the urine, we collect a 24-hour urine specimen as a baseline and continue to monitor that periodically to determine how the protein levels are doing in response to treatment. We also check other laboratories, including LDH and beta-2 microglobulin, which will again give us a feel for how someone is responding to treatment. Those numbers are expected to drop as someone is responding to treatment. Based upon the type of immunoglobulins, IgG, IgA, and IgM being the three immunoglobulins that we routinely check, we classify these patients as an IgG myeloma, IgA myeloma, or IgM myeloma, depending upon which of the immunoglobulins is elevated at baseline. So how do we decide what treatment a patient needs? There are several factors that are taken into consideration when we are formulating treatment for a patient. It's really important to consider patient preferences. I always check with my patients to see whether or not they're working, their family's social support, and also their preferences as far as something that may sound routine but important, such as a wedding that might be important for them to attend, or a trip that they may want to make, or whether or not they want to continue working that may involve physical labor. And depending upon their preferences, their level of activity, their work productivity, also depending upon other illnesses that the patient may have, a cardiac condition or a kidney condition. Taking all that into account, we come up with a treatment plan. It is very important for me as a physician treating multiple myeloma as well as multiple other cancers to maintain quality of life for all my patients. At the end of the day, if the patient is doing great with cancer but is not enjoying life and is not able to continue with their daily life, it does not add much to the treatment for that patient or for me as a provider. So it is extremely important to take everything into consideration when we come up with a treatment plan. The goal of the treatment is to control disease and symptoms related to it. It's also important to take into account toxicity related to treatments. For instance, some of these medicines can cause neuropathy or numbness and tingling. And if somebody has baseline symptoms of neuropathy, I may want to cut down the doses of some of the medications we are administering. It's also important to see how convenient is the treatment plan for the patient. How far are they traveling from? Do they have support as far as somebody bringing them to the office? Fortunately, many of the treatments that we provide for multiple myeloma are outpatient, and the patients are able to come on their own and drive to the clinic for these treatments. Lastly, and very importantly, it's important to be a good steward and make sure that there is no significant financial toxicity to the patient. Fortunately, we are able to provide assistance toward multiple medications, what we call a drug assistance program from different pharmaceutical companies. And if patients have high copays, multiple pharmaceutical companies this day and age are able to provide copay assistance depending upon the financial status of a patient. And when we put all this together, we are then able to come up with an effective treatment plan that is easier for the patient to go through. So what is the goal of treatment? Remember, I mentioned multiple myeloma is a chronic disease, similar to, say, hypertension or diabetes, where we know we cannot cure them, but we certainly can decrease symptoms related to myeloma and also help at the same time provide improvement in overall survival. As far as symptoms, some patients, for instance, will present with a fracture of a bone because there is myeloma, lytic lesion in a bone that's fragile and can easily break, resulting in severe bone pain. And there are things we can do to provide symptom relief, which may include, for instance, radiation to the site of bone pain, or sometimes even medications that help control bone pain, in addition to other pain relief methods. It is very important, as I mentioned again, to me as a provider and to my patients, that we preserve quality of life. Patients need to be able to go on about their life as usual. And with all this, we're able to slow down the growth of myeloma cells, quicken the response to treatment, and lengthen periods of remission. We are in a great place for multiple myeloma as a disease today because there are so many advances in this field, and patients are living longer and longer, continuing their lives as usual. I have patients that are working full-time despite treatment. I have patients that are traveling across the world as they're doing treatments. I have patients that are out on the golf course every day playing and having fun while they're doing treatments. And all this makes it very rewarding to me as a provider to see my patients to be able to continue their normal lifestyle as they're going through cancer treatments. Most treatments for multiple myeloma are outpatient in the initial treatment phase. As I mentioned, this consists of pills and injections. While that will bring down the M protein significantly for most patients, it does not help to maintain long-term remission for most part. And so it's really important to make sure we can do something more for these patients to keep them in remission longer. And fortunately, through research, clinical trials over decades, we now know that patients that go through stem cell transplant after an initial treatment as an outpatient can stay in remission longer. So when I see a patient with multiple myeloma, my first question is, can I send this patient for stem cell transplant? Not all patients are eligible for stem cell transplant. In order to undergo stem cell transplant, which is autologous stem cell transplant, where we collect stem cells from the same patient and give it back to the patient, they have to have certain physical condition, what we call a good performance status. We also need to make sure that they don't have other significant illnesses, including looking at their cardiac function, looking at their kidney function, and other illnesses or what we call comorbidities. And we also take age into consideration, where in general, stem cell transplant is considered for someone less than 75, maybe maximum up to 80 years of age. And that is because as people get older, it is harder to go through this process. Why is stem cell transplant hard? It is because it involves admitting the patients to the hospital, where we will collect stem cells followed by giving them high doses of chemotherapy to ablate their bone marrow and then give them back their own stem cells. And that process can result in dropping blood counts, infections, need for transfusions, and so on. So for patients that can go through stem cell transplant, we typically will do what's called as induction treatment, the outpatient treatment with either 3 or 4 drugs, what we call triplet or quadruplet therapy, and then send them to a transplant center, such as Northside Hospital, for stem cell collection, followed by autologous stem cell transplant. For patients who are not able to undergo stem cell transplant, we will do induction therapy in the office, followed by continuation of the same treatment and maybe taper it down a little bit to make it easier so they can stay on these treatments long term. I have multiple patients that have gone through both kinds of treatments, including stem cell transplant, as well as those who are not able to do transplant and are staying in very good disease control. If a patient does undergo stem cell transplant, they are subsequently maintained on a medication, such as a pill called Revlimid. Sometimes we add on an injection treatment to it. If we're not doing a stem cell transplant, then as I mentioned, we will taper down again the treatment to just a pill if we can, and continue to monitor these patients. In addition, we also provide what's called a supportive care. For instance, they may be on a bone strengthening medicine like Zometa, which is given every 3 months to help with control of the disease as well as maintaining bone strength. Once stem cell transplant is completed and patient is on maintenance therapy, we monitor these patients very closely with all the blood tests and urine tests that I mentioned before, including serum protein electrophoresis, urine protein electrophoresis, serum pre-light chain ratio, immunoglobulin levels, and so on, perhaps even bone marrow as needed, to see how the myeloma is doing. If we start detecting rises in M protein or light chains, that is called relapse disease, and patients may go through multiple relapses in their journey. What's very important to know is this day and age, we have great treatments even for relapsed myeloma. So if a patient has a relapse, we put them right back on treatment again, maybe a combination of drugs, which will keep the disease at bay for a certain length of time. And as we're monitoring it, should they relapse again, we have fortunately other treatment options that we can build on. And sometimes patients may have multiple, for instance, even up to 4 or 5 relapses in their treatment journey. I have patients that have been on treatment for multiple years, going into a decade, with relapses along the road, and yet doing very well with their current treatment. However, there might come a time in certain patients where after relapses, they're no longer responding to treatments, and we call that refractory disease. So what are the commonly used treatments for multiple myeloma? This can be broken down into different drug categories. One very common treatment used for multiple myeloma is steroids or corticosteroids, commonly with dexamethasone, sometimes with prednisone. They do have side effects, however, very manageable. For instance, it can cause insomnia, maybe some mood disturbances, maybe some muscle weakness. It can flare up diabetes. However, important to know that we work with other comorbidities to make sure that these treatments are tolerable. For instance, if somebody has diabetes, oftentimes I will reach out to the patient's endocrinologist or family physician to alert them that the patient is on steroids and may need a very tight control of their diabetes, perhaps insulin shots, to make this possible. As far as insomnia, I usually tell patients to take the steroids first thing in the morning so that they are not having sleep disturbances if they take it at night. Other medications, pills that we give to these patients are called immunomodulatory agents. The common ones being lenalidomide or Revlimid, pomalidomide or Pomalyst, and thalidomide. These treatments have rare side effects, including blood clots, dropping blood counts, skin rashes, sometimes some nausea, as well as neuropathy. We monitor our patients very closely for symptoms related to these complications, looking for things such as swelling of the leg or any shortness of breath, which will prompt us to look for blood clots. We check blood counts closely and also make sure that we ask patients for other side effects, including development of neuropathy with any numbness or tingling. In addition to the oral medications above, we have other medications we use, which are in the form of either intravenous medications or injections. A category of drugs called proteasome inhibitors are a very important part of treatment for multiple myeloma. This includes bortezomib, carfilzomib, and ixazomib. And these medicines can cause neuropathy. They may also drop blood counts, may cause dyspnea, and these are symptoms that we are very alert to and continue to ask our patients in their treatment journey to see if they're developing any such symptoms. We also use monoclonal antibodies. These are immune therapies called daratumumab, elotuzumab, and isatuximab, which sometimes can be associated with what we call infusion-related reactions or an allergic reaction, which are easily mitigated by preventing them with other medications such as Benadryl or Singulair. We also use other agents called melphalan and cyclophosphamide, what we call alkylating agents. These are typically employed at the time of stem cell transplant and can be associated with low blood counts or nausea. And then lastly, the newest kid on the block, so to speak, are T-cell redirecting therapies, one of which is called bispecific antibodies, and the other one is CAR T-cell therapy. For myeloma, that includes teclistamab, talquetamab, cilta-cel, and ida-cel. These are novel therapies that have really revolutionized treatment for multiple myeloma, and I have multiple patients that are on these treatments who have been refractory to standard treatments and responded very well to these treatments and are now in remission. These are associated with a unique side effect profile called cytokine release syndrome, which warrants hospitalization either through the course of treatment or at least during the initial phase of treatment. It can also be associated with neurotoxicity, which is also called ICANS, which is basically toxicity in the brain resulting in symptoms such as confusion or speech difficulties, etc. Going into a little more detail about autologous stem cell transplant, as I mentioned, we give 3 to 6 cycles of induction therapy. That is typically done as an outpatient. And then we send the patients to a stem cell transplant center, such as Northside Hospital, where they will collect the stem cells after giving certain injections to help boost stem cells that are collected through just a routine blood draw. And this may be multiple times when the patients get stem cells collected back to back 3 to 4 days in a row. And then we freeze these stem cells to use for the day of transplant. Once the stem cells are collected, we give the patient high doses of chemotherapy to ablate the marrow. And once the marrow is ablated, then we return the stem cells back to the patient after thawing the frozen product. And these stem cells will then go on and make home into the marrow, making newer cells without the cancer in them. So it's a pretty cool phenomenon. The day that infusion of stem cells is given back to the patient is called day 0. And from there on, we monitor post-transplant course as day 1 to day 100 plus. Typically, it takes about 100 days, roughly about 3 months, by the time the patient is starting to recover their blood counts, and they go back to their community physicians who will then continue care for their myeloma back again as an outpatient. Important note, the main goal, again, of the autologous stem cell transplant, as I mentioned, is to provide a deep response with a long-term remission. And multiple studies have shown that patients who are able to undergo stem cell transplant can stay in remission longer than those who are not able to undergo stem cell transplant. Of note, there is some debate about the utility of stem cell transplant this day and age with multiple great treatment options. However, it still remains the standard of care as of now. So once the patient has gone through treatments, we are continually monitoring the deceased regardless of what phase of their journey they are with respect to the treatment, whether it be induction treatment, whether it be post-transplant or refractory treatment. We are continually monitoring the myeloma protein, either in the blood or urine, which is typically drawn after each cycle of treatment. We do perform a bone marrow biopsy periodically as needed, Typically, if somebody undergoes stem cell transplant, we will do a bone marrow biopsy before and after transplant. If they are not going through a stem cell therapy, we may choose to do another bone marrow biopsy at about 4 to 6 months after starting induction therapy, or any time that we are suspecting a relapse. We also periodically monitor the bone lesions by imaging, such as PET scan. And typically, if somebody is undergoing a stem cell transplant, we will repeat the PET scan before as well as after the stem cell transplant. If a patient is not responding to treatment of myeloma and is not able to go into remission anymore or improve substantially after treatment, we call that a refractory myeloma. These patients are refractory to the treatment that they're getting and are just not able to go into remission. A relapsed myeloma, on the other hand, are patients who have initially responded to treatment. However, the disease returns after several months after being on the treatment and is less ominous than the refractory myeloma. Fortunately, this day and age, we are able to treat both refractory and relapsed myeloma with some of the novel therapies, for instance, CAR T-cell therapy. CAR T-cell therapy is called chimeric antigen receptor, or CAR, which is a genetically modified T-cell. This is a type of immunotherapy. Here we use one's own immune cells and redirect them to target the myeloma cells. This involves collecting a patient's white cells. We send it out to a manufacturing process where they isolate and activate the T cells and engineer the T cells with what we call a CAR gene. And then we grow it and expand the number of T cells and infuse the same patient with their own engineered T cells. These T cells then expand further into the patient's body and attack the myeloma cells, thereby putting this patient into clinical remission. A bispecific antibody therapy is also one of the novel treatments that we now use. The good news about bispecific antibody therapy, as opposed to the CAR T-cell therapy, is it can be administered as an outpatient after an initial brief hospitalization. For CAR T-cell therapy, typically all treatments are done as an inpatient. However, for bispecific antibody therapy, the inpatient hospitalization is roughly about a week, following which additional treatments can be done locally back in the community with the initial oncologist. So what is bispecific antibody therapy? Here we use an antibody to link a protein on the multiple myeloma cell to the patient's own immune T cells. In other words, it redirects a patient's own immune cells to find and attach the malignant plasma cells and attack them. So in summary, multiple myeloma treatment has come a very long way. I always tell my patients and remind them that this is a chronic illness and we are here together with them in their journey with this disease. This is one of the most treatable cancers anymore, and patients are living longer and longer and continuing to live a great quality of life. Most patients are able to do what they normally do in their lives, and that includes traveling as well as working and having fun. Your healthcare team is here to help, provide education, empower you through knowledge. And it's really important to ask your providers questions as they come along. Very important to discuss any potential barriers to care, any challenges that you might be facing at home. Please do not be shy to reach out to multiple healthcare providers that touch you in your journey, which may be your doctors, nurse practitioners, physician assistants, treatment nurses, as well as other healthcare providers, including social care workers, nutritionists, and so on. It's important to be informed about your health. Very important to find a healthcare team that you feel very comfortable with. I always end a patient visit by asking my patients if they have any additional questions. And do not hesitate to ask your physician if there are additional questions before they walk out of the room. You can always call back your healthcare team with additional questions if you have forgotten to ask those questions during the visit. This is a chronic illness, as other chronic illnesses such as diabetes and high blood pressure. Compliance is very important. A lot of these treatments, as I mentioned, include oral medications and injections, maybe multiple visits to the office as needed, and it is very important to keep with that plan so that we can continue to attack the myeloma cells and keep the disease in remission. There are also multiple support groups throughout the country where other patients with myeloma can share their journey with you and empower you in your journeys. There's also a survivorship care plan that your provider can provide to you. And it's really important to discuss all these aspects of your care with your team. Thank you so much for your attention. Please do not hesitate to reach out to us, even if you have any general question regarding multiple myeloma or any other cancer that we can help with. To get more information on the support groups available to you, please visit Cancer Support Community Atlanta at cscatlanta.org. There you can see all the oncology support programs that are available to you at no cost. Thank you again.
Northside Hospital Cancer Institute's Blood Cancer Coordinator is available to provide one-on-one patient support and education to help guide you through your treatment journey, providing education and resources to help you better understand multiple myeloma. You can contact the Blood Cancer Coordinator directly to talk through any additional non-urgent questions. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.